Dzień dobry, good morning, bonjour. Thank you for your invitation today. So I hope that my presentation is going to touch on some of the things that have already been discussed this morning. What I would like to focus on is the idea of compassion, because dignity and compassion, particularly at end-of-life care and in long-term care, are absolutely related. You cannot really separate them. And I also then want to focus on an issue that our previous speaker talked about, which is the issue of burden and burnout, and why we need to create opportunities for compassion in the way in which we deliver our clinical care. And you'll see the book I have noted here by Christopher Germer, which is The Mindful Path to Self-Compassion. So the message for today, the key message from my presentation, is that compassion begins with you. You are the only people who are able to identify what the compassionate needs of yourself are as a caregiver in the context of caring for those who have end-of-life or chronic care needs. So what do we mean by compassion? I suppose an opening question is, and I do this when I teach my students, what is the experience of compassion in your life? And have you ever experienced a lack of compassion towards yourself or others? This is often an opening when you do reflection with clinical staff about their experience of compassion. Most people can find evidence of a lack of compassion, experiences where they felt care could be better, but they often find it hard to describe in detail an experience where they have received compassion. And if they can, it helps them to develop their thinking and their practice in terms of how they would give good, compassionate care. Compassion is a global phenomenon. Every culture in the world has some description or definition of compassion. The world religions or faiths all describe compassion as a critical element of how we are in society. And in fact, that is probably one of the first things to consider. Here in Poland, where is compassion in your society? I'll come back to that in a moment. Is the way in which long-term care is given compassionate? Or are there times when perhaps because of the system or because of the structure, the care could be given in a different way, in a more compassionate way, but we feel blocked or powerless to change something that already exists? The second issue is we often get compassion confused with other elements, and one of those is empathy. So I want to refer to this particular book by Marie Vachon, who is a nurse from America, and Darcy Harris, who is a specialist in death studies, and they talk about the issue of empathy. So in many ways, we need empathy, which is an awareness of another person's experience as something to be understood, but not always related to suffering. That's an important point. We need empathy to unlock the door to compassion. So the easiest way to consider the relationship between empathy and compassion is to imagine a door with a key and a lock. And the empathy is the key that undoes the door to compassion. When you cross over the threshold of the door, when you carry out an action which is a good action, that is a compassionate action. So compassion is really only noted by the action that you take. It is not just the feeling. The feeling element is empathy. And I think that's often an important definition or description to understand what we mean when we talk about compassion. The other thing that people often ask me is, are we automatically compassionate? I have said here, are we wired for compassion? And so I want to give you an example. The gentleman you see here is a French Buddhist monk, and his name is Mathieu Ricard. And there was a very big study done in the Max Planck Institute in Munich, where they brought together people who had no experience of meditation, compassion meditation, and those who were very expert. And they placed them in a large room like this, and half of them was on one side, those with no experience, those with experience on the right. And everyone was wired up to neuroimagery. And Monsieur Ricard sat on the stage and he conducted a silent compassion meditation. And they were able to see neuronal changes in everyone in the room, even those who had no experience or no understanding of meditation. So we do know that our neural networks are connected, and when we see suffering in front of us, we react in a deep way, and that in effect is a compassionate response. So the Max Planck Institute in Germany is doing a lot of research to try and understand what is it about compassion that connects us as human beings. There are, of course, many definitions, and I'm going to use this one because it's one that we use a lot in palliative and end-of-life care. And it's by a theologian and philosopher, Henri Nouwen, who wrote this little book on compassion. And he says to us that compassion asks us to go where it hurts, to enter into places of pain or brokenness, fear, confusion, and anguish. Compassion signifies the total immersion in being human. That's an awful lot to ask of our clinical staff every day. And I'm always very clear with the people I work with, because I have a clinical role, I work as part of a palliative care service in Lausanne, that this is not something that you can do 24 hours a day, 7 days a week, without some way of healing yourself, some way of looking after your own health as a caregiver. Because particularly with patients who are in need, who may be desperate, who may be in pain, we feel the need as professionals to give. But if you continue to give and do not find a way to replenish your needs, then you risk burnout. Then you risk the end of your career because you have nothing left to give. So this is an important definition, but some days it's good enough to be a doctor. It's good enough to be a nurse. It's good enough to be a healthcare professional. Nobody expects you to be a superhuman being. One of the key issues with compassion is it is always a response to suffering. You need to see suffering in order for compassion to occur. And in our world today, we see many examples of suffering. Now, there is research that shows that where the suffering is in relation to where you are, so if, for example, we see these images on the television, our reaction is somewhat different than if we were physically there at that moment in time, if we were with these people. But the compassion itself is real. So the point about suffering is that we have a responsibility to acknowledge that suffering exists, and we also have a responsibility as professionals to try to address that suffering if we can do so. I mentioned this earlier, but I must come back to it because it is important. I think the starting point to address suffering is to understand what compassion is in your culture. And you need to consider your history, where your people have come from, how your people have grown, and what impacted on those aspects of Polish life that makes you the society that you are. So I work in Lausanne, but you can probably tell from my accent I'm not Swiss, I come from Ireland. And so I use my own example to help you. So on the top you can see a nice picture of the lake. I come from the west of Ireland, I come from Galway, and this is the back of my house, very pretty, very beautiful, and people think Ireland is a beautiful, mystical country, very nice, lots of pubs and things, very good. But when I was a child, we grew up in a divided society. I grew up at the time when we had political wars because of religion, when we had division because we came from different communities. And we lived at a time of destruction. We found a way through that. We found a way which we called the Good Friday Agreement. And the Good Friday Agreement was based on the fact that we believe that we can work better together in a compassionate way. But I cannot deny that those aspects have had an influence on who I am as a professional and who I am as a person. And it's important that we think about those things if we want to develop compassionate care for the citizens of our country. I know that this is a difficult image to see, but it's a real one, and actually it tells you the story of good palliative and end-of-life care. You see the soldier witnesses the suffering. He witnesses a tragedy. But he doesn't just witness it. He picks up the little boy and he moves that child to a place of safety. Every single day in your work, that is what you do. You witness the suffering of another person and you carry out an act, a compassionate act, to try to relieve that suffering. You provide medication. You comfort them when they are crying. You help their families to understand the transition that they're making towards the end of their life or their old age or their dementia. And so we can't address suffering unless we have the courage to acknowledge it. And we need to do that by asking the right questions of ourselves. Am I in the place to do this work today? And also of others. What is it that you need from me so that you can cope better in this difficult situation? But most importantly, as is a message I often give to the young medical students, is you have to have the strength to stay and hear the answer. Because it's very easy to deliver bad news. The difficulty is when you have to wait for the response. And so we have to learn and teach the young students how they can become better at staying present to the suffering of other people without it overwhelming them. And that is a key aspect of compassionate care. So, palliative care as its nature, the care of people, particularly at end of life, pallium comes from this idea that we cloak or cover. It doesn't mean we hide away. It simply means we accept the reality that we cannot change the inevitable for people. People will die. People in our long-term care facilities will become frail. They will need greater care. But our aim in every respect of this is to try to heal, is to try to find ways of healing, maybe even through rehabilitation in some cases. But the key aim here is that we are always able to help find a solution. And even when solutions are difficult, the key issue is that we are often the solution ourselves. And the founder of the palliative care movement, Cecily Saunders, and I think this is a very important message, the presence of another person is an isle of security. So in fact, one of the things that people tell me is, I don't know what to say. I don't quite know how to respond here. And my response is, you don't have to. The very fact that you have the courage to be there is important, because your presence may be enough just to help that person to survive. And actually, one of the groups of people I work with who are really good at this are healthcare assistants. Not the qualified staff, but those people who work with us, because they come from a different perspective. And often they're closest to the patient in those difficult moments. They're often the person who's with them when they're perhaps upset or when perhaps in the middle of the night they're distressed. Often the healthcare assistant is the person who's there to help them most. So let me just look at dignity and why that might be important, particularly if you're caring for people at end of life. Immanuel Kant, the philosopher, is very clear on the fact that dignity and respect are inseparable. And respect is a key element of what we try to instill in the care that we give, particularly in the compassionate care that we give, because you cannot separate them. But one of the points that he makes here is that dignity begins with a deep understanding of our personal dignity and our self-respect. So in organizations where you do not feel respected, or you do not feel that your personal dignity and worth is respected, it can be very difficult to find ways forward to care for others. And therefore, compassionate, dignified care is not simply the responsibility of the individual, it is the responsibility of the organization. The organization needs to adopt strategies to support you in your compassionate caregiving. And if they fail to do so, then they fail the people that they care for, because you are the way to provide that care. So true dignity at end of life means the full meaning of respect, the fact that we have a right to privacy. Certain things, we have a culture, I think, of a lack of confidentiality sometimes, and we have to be conscious how we manage that in respecting people's lives. We need to understand the relationships that exist. Who are the people who are important to the person we care for? And why are they important? And how can we help them? We also need to understand that it provides an opportunity. If you understand dignity, it provides an opportunity for the person to share with you the most important things that they want in their last days. And that's really about allowing them the space to present what they need, to share what they need, and to describe what they need. So in relation to dignity at end of life, it is a response to vulnerability and the desire to care for others. And for those of you all working in long-term care, you will know that some people are extraordinarily vulnerable. I work in Lausanne with people who have dementia. I work in nursing homes with people who have dementia. I also work with people who are homeless. I work with people who have drug addiction. And all those people are vulnerable for different reasons. But when people are vulnerable, they need help to avoid harm to others or harm to themselves. But we can't avoid harming them if we don't understand the reasons from their vulnerability. So when you see your patient for the first time, and we arrive with many documents to fill in about their Braden score and their dietary intake and all of this, the first question can often be, tell me something about you as a person. Learn something about them, because the rest of this will come. We'll need that, of course, to plan your care, but I need to know a little bit about you. So the dignity of care at end of life begins with the total respect of the other. And that is, my first question is, tell me something about Phil Larkin. And from that, I can build my care. Why do I say end of life is important? Well, I'm 38 years working in palliative care, so I obviously think it's important. But the truth is, and you have this experience too, when you are caring for people as they come to the end of their life, you only have one chance to get it right. You can't go back and do it again. You can do it better with someone else. But if you failed for some reason or something didn't work, how do you actually debrief that? How do you actually manage that as a team? When care hasn't gone well, are there systems that allow you to discuss your experience? And there are some very good examples from many countries, including Ireland, my own country, where they have what they call a death review, where they come together after a death to talk about the experience of caregiving, where you're not looking at did they have the right medication or was the care plan correct, but what was the impact of care? Was the care given with the best intention? These are important elements in terms of dignified end-of-life care. And why is that important for us as clinicians? Well, it's important, as I said, that you understand the meaning of suffering. But you also need to learn the language of talking about difficult questions. I'll mention that in a moment. It's very important that we learn to hear the voice of others, but it's also that we learn to respect the boundaries of our own competence, of our own skill. And that's why palliative and end-of-life care, in as much as long-term care, should be delivered as an interprofessional, interdisciplinary practice. We all bring something important to the table, and we need to learn to share that. In certain systems, there is a hierarchy, and we can't change that. But we do need to make sure that the voice of the individual professional is heard in the planning of care, so that we know that all the elements, physical, psychological, social, and spiritual, are met for the patient in the best way possible. So how do we create opportunities for compassion in your care? So one of the exercises that I do with my staff is I ask them when they come to work with us, what brings you to the work and what sustains you in the work? And what that means is, you can come to visit or come to work in a palliative care unit and you may have an excellent CV, many years experience, master's degree, PhD. That isn't going to help you in this work. What helps you in this work are the things in your life that make you the person you are. Do you like to spend time with your family? Do you like to go in the mountains or in the lakes or enjoy the outside? Do you dance? What are the things in your life that make you you? Because in the difficult times of care, it's what sustains you that will enable you to continue in the work. And if you tell me it's my life's work to come and work with dying people, it rings a bell in my head. It's nobody's life work to do that. Some people are good at it, and that's great. But the point is, you need to think about the health, your own health within this. So things which sustain you in end-of-life care are critical to your survival and also the good care of your patients. And how do we do that, or why is it important? Well, I think that you can reflect this. This is a work by a very eminent Irish-American palliative care physician called Michael Carney, and he was talking about the role of physicians in care of end of life. And basically he said, those of us who choose to work in this area, we have three particular elements. The first is that in the work that we do, if you reflect this in terms of long-term care, we facilitate people letting go of health, letting go of capacity, letting go of memories, letting go of physical abilities to do things, moving perhaps towards the end of their life. It's all about the quality of care that we offer. So the quality of care may be slightly different than perhaps a patient might receive in an emergency department, an outpatient clinic. There's something about the quality of care that you deliver which makes it a little bit different. And finally, it's because you realize that actually, beside all the polypharmacy and all the medication, you're often the most important medicine for your patients. And once you get that message, then that will sustain you in palliative and end-of-life care. Even wherever you deliver that, you are the most potent medicine for your patients. In terms of the work, it's certainly clear to me that this is Ira Byock, a very well-known clinician, a palliative care physician from America. And he wrote this book about 4 things, and these are the conversations that you hear. And I know you hear these in the long-term care situations because I know with the ones I work in Lausanne. You will hear people talk about, please forgive me, I forgive you, thank you, I love you, and sometimes goodbye. And we have a responsibility to negotiate those conversations for people where they wish to do so. But each of those will impact on you as a caregiver when you have to be part of those conversations. So think about afterwards, take a breath after each of those conversations, because they're heavy. They're not your conversation, they're someone else's, but you have to witness those. The witnessing is key to the compassionate response. You also have a role, I think, particularly in end-of-life and long-term care, in terms of helping people to reconstruct some part of their lives that may have become broken or may have become damaged. But you can never do that and make it perfect. And I think that's a really important message that we need to make sure patients and families understand. We always do our best. It can never be perfect, but we will make it as good as it possibly can. Because when you repair a broken pot, it's never the same. There's always a little gap, and we have to learn to live with the gap. We can't change it. So in effect, one of the things we need to learn is the language of compassion. And in my work, particularly in palliative and end-of-life care, to be able to speak to people appropriately around death and dying. That can be difficult. Switzerland is a multicultural country. In some countries, it simply wouldn't be appropriate to talk about death, in some cultures. And we have many languages, which could make it difficult as well in terms of communication. But we have a responsibility because you may be the first person that has ever broached the topic of death. And somebody may need to do that given the nature of someone's illness. And that may open a whole other conversation around life and death, and what does that mean, and what sort of person was I. So in a way, we have to learn a whole language of compassion, a language that says, I'm here to listen to you, but I'll give you some prompts, I'll give you some help to enable you to start that difficult conversation. And so I'm coming to the end. I want to just share with you this idea of the intuitive self. When I was a student, we were taught that our intuition, our sense, was extremely important in practice. And then somewhere along the line, it all became evidence-based practice. Now that's very important. I'm not saying it isn't. But as a clinician, there's also times when you feel that there is something that is not right. So the statue that you see here, it looks very small, but actually it's enormous. It's a statue that is made of oak leaves. It's a statue near my house, and it's in Ireland. And it tells you a story, and it's the story of the goddess of spring. So in the ancient Irish story, when the winter was finishing and spring was coming, the goddess would listen underneath the ground to what was happening, and when she heard the first sound of the flowers coming up, she would tell the world that winter was over and spring had begun. Why is that important? Because often you need to learn to listen what's happening underneath. It's not what you see, it's what's happening down below. And so you need to think about, how do I find the time to do that? Because what you see is not always the story. And so you need to just wait for things to come up and things to emerge and address those as best you can. So my final thoughts, as I said at the beginning, you cannot have compassion for others unless you have compassion for yourself. So compassion always begins with a thorough understanding of what compassion means for me. And the risk, if we do not have compassion, is that we become burnt out. The image that you see here is by an artist, a friend of mine, but you possibly can see around the neck of the lady is a black dog, because in English they talk about the black dog of depression. And often it's very difficult when you see a situation where a colleague is struggling, a colleague themselves is suffering, a colleague is finding it difficult to be with patients or to be with the team. And we have a responsibility, a compassionate responsibility, not just to ourselves but to our colleagues, that where we see suffering, we address it. It's not uncommon to find clinicians who have difficulties with alcohol, with medication abuse, with family difficulties that they find difficult to address, but it becomes very evident in their work. And so we have a responsibility, a caring responsibility, to name and witness that suffering and help people so they don't end up in this situation and then find themselves unable to continue in their good work. And so finally, I suppose I go back to the point of this Henri Nouwen, who is the man who was the theologian about compassion. But basically, you are the difference that you make. So your training is important, your experience is important, your skills are essential. But fundamentally, every day, you make the difference. And often families, caregivers, because much of this, of course, also relates to the care that we give to families, they will often remember a little thing that you did. It won't be a big change, it will be a little thing that happened during the care of their relative that they will remember. And that's our job, is to make that an important memory for them. So I can leave you a final thought. So don't worry, I don't expect you to speak Irish, but it's an Irish language quote which says, "We live in the shadow of each other. We are responsible in a way for each and every one of us. You are all practitioners, you are all caregivers in some way. And so we live in a shadow. We don't live in isolation as a people, as citizens. And so we need to remember what that relationship is. And if you remember that compassion is networked through all of us in some way that we don't quite understand, then that shadow, that part that we share with each other, could be critically important. So I want to thank you for your time. I hope that you can find the compassion in yourself so that you will be able to find it in others and care for them. Thank you for your attention.
Bardzo dziękujemy I proszę zaprosić.
Thank you very much. And please ask questions if you have any. I will ask a question myself to give you some time to approach the microphone. Professor, certainly an important component of dignity in dying is a conversation, a very special conversation that you have mentioned. A conversation that has to include listening. And can we learn it somehow? Because on a daily basis we can see how important it is.
Yes, thank you. You know, there's the author, American author Mark Twain said that God gave us 2 ears and 1 mouth to use in that proportion. So in effect, the challenge is that we often feel that when people ask when we need to discuss difficult things, that we always have to have a response. But actually, the listening is the most important thing. And you can teach people listening skills. Clinicians generally want to try to do something. We're very active people. But actually, you can learn an awful lot from people who have a background in mental health, for example, because they're very skilled at being able to listen without interruption, without trying to challenge something. I do find that if we can teach the younger students, particularly these skills, and then they can watch you practice them, because they do need to see expert clinicians use these skills. Then they will instill them within themselves as practitioners and realize that they're important. You can do courses, but a lot of it is really about what you learn also from each other in your clinical teams. So I would encourage the idea of discussions and meetings in your clinical teams about the way you care, about what's important to you. That will help you to provide much better care, because you will all start to understand what each other's thinking.
Thank you very much. Bardzo dziękujemy.
Thank you very much, and I see that there are no more questions.